When you think about health care, do you shudder when you think of the cost? Can you afford it now? Will you be able to afford it in the future? Consumers for Affordable Health Care were at the Boys and Girls Club in Waterville on October 10th for just those questions about various health care options, especially affordability. You are invited to hear the results. You are also invited to contribute.
This is our fourth community discussion. It is the culmination of three others that we've done. We started in Lewiston. We traveled to Biddeford. Last week we went up to the county to Presque Isle, and we are here tonight in Waterville. Consumers for Affordable Health Care has been around for just about 20 years. We have our 20th anniversary next month, and we staff a large coalition of organizations. Those include the Catholic Diocese of Maine, the Maine Council of Churches. We have the Maine Equal Justice Partners, Maine Council of Senior Citizens, Maine Women's Lobby, and the Maine People's Alliance, to name just a few. There is probably no greater domestic issue facing us right now as a nation. We are seeing that as the presidential debates heat up. And from our perspective, we are at a very significant crossroads nationally, and certainly here in the state of Maine. Our goal as an organization, as a coalition, is to bring universal health care coverage to every man, woman, and child in this state, and that coverage should be comprehensive and affordable. That I'd like to introduce, or actually have the panelists that are here to my left introduce themselves, and I'd like to start with this fine gentleman right here.
Hi, my name is Joe Ditre, and I serve as the Director of Consumers for Affordable Health Care. Thank you all for coming.
I'm Sarah Gagne-Holmes with Maine Equal Justice Partners, and just to give you a little information about what it is that we do and who we are, we advocate on behalf of low-income individuals to be sure that there are systems and supports available for them to live with dignity and economic security. We advocate in the legislature, with the administration. We represent class action lawsuits in the courts.
You'll see a Divided We Fail brochure and pledge card. We ask that you look it over and just fill out that pledge card, and I'll be collecting those. It's basically to force any elected officials to we're demanding quality health care for everybody.
In your brochure, I put a couple of leaflets that show how much we're spending in Maine on health care, and $8.4 billion, and that was in 2004, and it's estimated to be close to $11 billion in 2008. And so our major concern is the cost of health care and finding a way of lowering those prices.
And certainly we're going to need everybody's help in this room to move a very comprehensive and positive agenda forward, starting in January and ending in April. I'd like to ask Joe Ditre from Consumers for Affordable Health Care to share some healthcare facts. We wanted to not make this so much a presentation on policy to you, but we felt it was important to lay a foundation and to give you a backdrop of some of the statistics that we're looking at with respects to health policy.
I want to point out that if any of you have a difficulty in getting coverage, or you have a difficulty in getting a bill paid, or if you had difficulty in affording your prescription drugs, for example, that there's an 800 number here in these materials that you can use. I wanted to just share with you a few of the facts about healthcare and the status of health coverage in the state of Maine as principles to use to evaluate health reform options. These principles are important in that they are really defining principles for how do you decide as citizens whether you're getting value for your dollar. When you hear a candidate speak and they say they're going to promise you healthcare reform, well, what does that mean? How do you evaluate when they say, well, here's my reform proposal? How do you decide whether it's good or not? So let me just sort of take you through these. Security means all Maine residents have comprehensive quality coverage that is guaranteed. 2, fairness. Contributions for coverage are based on the ability to pay. And just an important piece about this one item, fairness. The major problem that people have in getting coverage is that they can't afford to pay the one-size-fits-all premiums that insurance companies offer them. I can tell you that many insurers will say, well, if you can't afford that premium, well, how about this one? But when you look at what coverage you get for the lower premium, you realize why there's a difference. I always say, I can sell you an affordable car. It doesn't have an engine, but it's affordable. Equality. Coverage is provided on an equal basis regardless of your age, job status, employer size, geographic location, income, health status, or occupation. And you're going to be hearing more tonight about how insurance carriers have denied coverage to people on these bases. If you're older, your premiums are much higher. If you have a medical condition in the state of Maine before we adopted community rating and guaranteed issue and renewal, insurance carriers could deny you coverage simply because you were sick. Or they would deny it because you are a female of childbearing age. Stability. The costs of care and administration are contained to make coverage and contributions affordable and predictable for Maine individuals, families, and businesses. The way prices are going up so rapidly, businesses and individuals can't budget from year to year. If any of you have do any of you have the Anthem Health Choice product, the individual non-group product? They're proposing an 18 to 20% rate increase this year. That's on top of the 18% that they got last year, the 16% that they got the year before, and each of the increases for the past 5 years have totaled more than 100%. So in 5 years, if you're buying that product, you've seen your rates go up 100%. And finally, choice, that the coverage allows us as consumers to choose our provider. You often hear about the need for choices in our coverage, and that's quite deceptive because often choice gets complicated. When your choices include, for example, premiums, co-pays at varying levels, deductibles at varying levels, co-insurance at varying rates, and exclusions for coverage, covered services and non-covered services, the choices and the variables get so large that you don't know what you're buying. Most people don't even know what their coverage is. And it's because of this number of choices. When we talk about choice as consumers, we talk about meaningful choices, choices that enable us to compare price, quality, and service from one plan to another. When you try to compare one product to another product, I can guarantee it is virtually impossible because one carrier will say, here's the deductible levels, and your co-insurances are either 80-20, 80% paid by the plan after you pay a certain level of deductible, 20% paid by you, 70% paid by the plan if you use an in-network provider, 30% if you use an out-network provider. It gets so complicated that the consumer really doesn't understand on an apples-to-apples basis what they are buying. So we want meaningful choices, not just more choices. Very often you hear government shouldn't be involved in health care. Well, I scratch my head and I wonder, why would people say that when in fact the largest portion, almost the largest portion of insureds are covered by government programs? When you think about how we pay for health coverage, you also have to ask, where does the money come from, not what are we buying? And the reason I say that is that when you think about for example, our university system, the University of Maine system, the coverage is paid for, in part, for the individual teacher by the taxpayer, our state legislature. We pay for the coverage for the legislator. They have to pay for their family. For our teachers in our elementary schools, our middle schools, and our high schools, the taxpayer pays for the teacher, and they pick up the cost for their family. But as you start to count municipal employees, so when you start looking at where do the dollars come from that pay for this private coverage that the university and the municipality and the state of Maine is purchasing, the dollars are coming from the taxpayer. And so when you count up all those dollars, you see that almost 70% of the money that buys private coverage comes from the taxpayer. So it's not a big leap to say the other 30%, we can get the universal coverage. We just as a society have to agree we're going to buy coverage, but we're going to control the cost. We're paying 41% more than the next highest nation as a relative number to their percentage of their GDP. For example, France spends about 10% of its gross domestic product on health care. We, by 2010, will be spending 20% of our GDP on health care. Double. And we're getting less. We should be very proud as Mainers, okay? And the reason I say that is this. Of the 50 states in the United States, we have the 5th highest percentage of people covered in the country. About 90.5%, almost 91% of our citizens have some form of health coverage. And for that, we should be very proud. Texas has 27% of its population uninsured. Another way of putting it is 73% of its population is covered. Maine has 91% covered. Okay? And that makes a real difference because when people don't have coverage, they use their local hospital emergency room. And who do you think pays for those costs? When somebody can't afford coverage and they have to use their emergency room. Okay? And the problem is it's not just for us who have to pay that bill, but think of that person who is willing to pay money, wants to pay money, hardworking Mainer, just can't afford the one-size-fits-all premium. So they're locked out of coverage, and guess what? They wait really long to get care. And so not only do they use the emergency room absolutely when they have to, but it's at a point in their condition which could have been lower cost earlier, but also for their health would have resulted in a better health outcome. But when you're looking at, for example, a standard Anthem plan with a $1,000 deductible, you are talking about a premium that's $2,447 a month. Okay, that's a non-group family plan. And Megalife, which is the next largest carrier in the non-group market, is charging $22.59 for that same product. As you can see in the bottom chart, for the Anthem plan, that's $29,372 a year. A couple things that are clear from the conversations that we've had in Presque Isle, in Biddeford, and Lewiston. People have basically told us how difficult it is to have these deductibles at $5,000, $10,000, and $15,000. And in our organization, we say the only thing worse than being uninsured is paying to be uninsured.
What we're going to do now is to break it into some small groups, and actually you're already in them. That's why we've chosen the roundtables tonight. And there's an individual that's going to be at your table representing one of the organizations of our coalition. It's going to help you facilitate this conversation for the next half an hour. And what we want to encourage you is, what are your thoughts? What do you think? How should we get to universal coverage? Is healthcare a right or is it a privilege? Should it be based on your ability to pay? And what kind of coverage do we deserve? And if you also have any serious and really personal issues that you feel comfortable talking about.
I presently work for the state doing education and organizational development, but I'm interested in moving into a more creative, more artistic work, but I would be self-employed, I'd be the sole proprietor. So as we talked about in your introduction, my premiums would go past the penthouse roof.
I am in the Maine Council of Churches, and I came here tonight because I received a flyer. As far as insurance questions are concerned, I have only negative to report. We were a very short time late in paying our annual premium to Anthem, and were promptly canceled.
And as an insurance agent, we made a lot of money in the health field. Simply converting old policies to go along with what Medicare did not cover.
Karen works in the doctor's office. I have read extensively and watched healthcare issues continuously, and to figure out a system that's set down in one of those flyers to figure out what you're getting covered, and read the small print down at the bottom. I don't care how intelligent you are, you're dealing with someone on the other end of the phone in East Texas somewhere who has
We found the same thing with Medicare Part D. Our son has Medicare, and to try to understand when they came out with Medicare Part D, what the heck we were supposed to do.
We also have some wondering about why insurance companies and drug companies aren't held accountable for all the people who are dying, who are uninsured. And large corporations even are having a problem competing in this country with overseas companies due to increasing healthcare costs.
There was the statement that if we weren't putting so much money into the military, maybe the government could put more into health care. There was also the statement that we ought to do something to change it, and we ought to throw the bums out, was the statement.
And he didn't have insurance up until that point, and he said how different he was treated in the doctor's office when he walks in with the insurance card versus when you don't have an insurance card.
Of being a physician used to be a service job. It was not the religion that it is now, where they're put on a pedestal and they know it all, but all they know to do is prescribe drugs that the pharmaceutical companies are coming in and pushing and telling them this is what they need to prescribe. So it seems like there's a chain where people are helping each other for the profit.
We do have in the state, by the way, a state health plan. And every time I mention it, everybody will say, where is it? Now, the fact is that we don't have enough money in the state government to produce it. But there is a state health plan. We have to take and have the profits, health care instead of profits. Health care has to be first and profit has to be second.
We often hear about waiting lists in countries with single payer, but the truth is waiting periods for some specialty treatments are as long, if not longer, here.
All bankruptcies, individual personal bankruptcies in the United States in the year 2001 were the result of medical debt. People not able to afford the care or coverage that they received. 75% of those 46% of those people that filed for bankruptcy had health insurance. Let me connect that to a point. In the legislature, there are proposals that would actually require you to pay even more.
The program is currently capped, and the only way you can get Dirigo Health right now, the insurance product, is if you pay the full amount. So there's no subsidies available for it. We are hopeful that this session we can pass a Dirigo funding bill that will allow the program to remove the cap and have that sliding scale subsidy available again for individuals.
And the question was, are the public programs paying too little, or are the private programs paying too much? And we quickly, as members of the commission, came to the question of, well, what are the real costs? And the issue then was, well, what are we buying? And it was very interesting when that question was asked that it couldn't be answered. Because when basically the costs are reported, the way that they're reported, it includes things that don't include care. And what we found was there was a lot of incentive within the system to build new buildings, to buy new technological equipment, to basically drive a higher demand. It's like what we talk about with the drug companies. You know, they go out, they market a lot, and they say you absolutely need this because you have restless leg syndrome or whatever. And all of a sudden you think that you need this, and you go to your doctor, can I have this? These things that weren't used before are now built into the cost. But the problem is it's not that we don't need new technology. The question is, does every hospital need the new technology? Does every provider have to have an MRI or a CAT scan or a PT scanner in their office? And do we need all of these new buildings, equipment, and technologies, and all these new pills? And so when you start really looking at the costs, you start saying, well,
health insurance should not be a business. It shouldn't be in the hands of all the for-profit insurance companies around. We just need to get the profit out of it. We need to get the insurance companies out of it. And we need to do this really fast. And how fast are people willing to start organizing and really saying no more?